Thank you, Dr. Rinkesh. I think that was wonderful. Dr. Gajanan, are there any questions or should I fire off? I have quite a few questions which I want clarification on from these two experts. In my day-to-day practice, I have these problems. Dr. Gajanan,
I
have you
think,
got any
yes,
questions?
sir. What I feel, I think you first interact with the speakers.
Okay.
There are questions we have received, but we'll take those questions
Yeah,
once.
yeah. And then I'll ask you, you can actually
Yes.
pose those questions on behalf of the doctors who have asked. Okay.
Yes.
So, okay. So let me first start with a very common problem that I face day to day, Dr. Zubin and Dr. Inkesh. So one of them is, the example that you gave, Dr. Zubin, 50-odd-year-old woman with a 3 kg weight loss, okay, uh, persistent dyspepsia. So when you ask for an endoscopy, primarily, I'm sure the person must have taken a PPI, by that time somebody has given it. So when you are actually doing endoscopy, uh, what would be at the back of your mind? Would it be that, look, since cancer is a possibility and you don't want it to be overlooked, because I think waiting for a lump and drop in hemoglobin is always implication implies that it's a late stage. So you have the person scoped and the report comes as, uh, there is no cancer, there is no ulcer. In the meantime, during your interaction, you have discovered that she is undergoing stress because her daughter is giving her boards, class 12 exams. Uh, so here, uh, during endoscopy, there is nothing alarming, but it comes out with a H. pylori positive, so RUT positive. Okay. Now, I want it in a very balanced way, not theoretical. Okay. So in India, roughly in your practice, when you scope and do a RUT, what proportion of patients do you find are positive on the RUT test, the rapid urease test?
Almost 70 to 80% are positive with rapid urease. Yeah.
Good. Now, if you get a person of this type who is RUT positive, how likely are you to believe that it's the H. pylori infection which is causing the dyspepsia rather than the stress? So that's one question. And then would you offer treatment for H. pylori right there? I mean, the implications of my question, I wanted to be clear to all the audience. We are caught in a trap. The therapy implications are you have to give two antibiotics, usually clarithromycin and amoxicillin, for 14 days, and the doses are pretty high. And most of them who tolerate it, they would anyway feel nice if they have survived those 2 weeks. Okay. So, is the benefit indeed related to the H. pylori going away, or is it because we have found something as a something to blame, so that we can put our finger on it? So, how do you manage these patients?
Sir, I
Straight.
look, sir, there are two things I look at on endoscopy apart from the IUT in these set of patients. One thing is that is it my incidental finding of H. pylori? Okay, I took an IUT and it is positive, or there are changes on endoscopy like atrophic is there, or some duodenal ulcerations are there, or some definitive gastritis is there. If I have an independent indication to start H. pylori based on these findings, I will treat them because then they can be harboring the symptoms because of that. Theoretically, again, I'll say that yes, the definition of functional dyspepsia would merit that we have excluded an H. pylori associated dyspepsia. But practically, if my patient, history wise is sounding like it's more of an anxiety or a stress related disorder, and there are no such findings on an endoscopy apart from the incidental RUT, I'll probably wait before I treat for H. pylori. I'll probably give them more counseling and offer them symptomatic based management with ecoshiamide or other prokinetics, and then see if I really need to treat any more than that.
Oh, good, thank you. May I pose the same question to Dr. Rinkesh? So, Rinkesh, difficult problem, as you know, day-to-day practice. See, the question is that when you treat patients with H. pylori infection and dyspepsia, in my practice, I find that about a third of them come back feeling that, yeah, after H. pylori treatment, I am better. But at least two-thirds, they don't improve and they think that the ordeal of treatment has been high. Number two, as a senior physician, you know that our uh, incidence of uh, C. diff infections, Clostridium difficile infections are going up. In the last 3 weeks, I think we saw about 3 patients of C. diff, if you remember, you and I. And, I mean, with very little provocations, none of that clindamycin story. So, are we likely to create problems with a long-term therapy of H. pylori, or how do you draw the balance?
Sir, very important question. And yes, sir, regarding that antibiotic usage in every indication, in fact, there are lots of unnecessary antibiotic usage are there, and specifically in H. pylori, we are as a gastroenterologist or as a physician, we are using more than required. The issue is, yes, with the like Dr. Jobin said, that there are some particular indication. H. pylori alone is not should be the indication for H. pylori treatment. There should be some changes along with the H. pylori RUT positivity, some typical atrophic changes or ulcerations, which we can contribute to the H. pylori. Then we should treat with the standard regime. But if there is a nothing specific finding, then I think we should just wait and watch. Sometime these patient, as you rightly said, one third improves with the antibiotic, but if we wait, that one third also improve without any for any antibiotic or any H. pylori medications. So I think we should wait, sir, if there are no alarming
I
symptoms.
think that physicians are actually, they know their patients very well and they can take their discrete decisions. But anyway, I just wanted to bring out a flavor of how difficult it can be. There's a question from Dr. Girija Nair. Hello, Dr. Nair. So patients don't get results in 1 to 2 weeks if they don't get it. So how long it takes to get complete relief? So that's one question. So whenever you treat dyspepsia, what's a fair time that you would think that the relief should come, if at all it does?
Generally, I think 2 weeks is sufficient, sir.
Uh, your thoughts, Zubin? I remember seeing that study on nicotinamide long time ago, and I think the graph started improving after a fairly longish lag period. What I'm trying to tell you is that the response may not be very quick, as people might like to believe that within 24 to 48 hours. So, what would be a reasonable time before you call the patient back to say there is no response?
So when I start them on PPI and nicotinamide combination, I usually bring them back at 4 weeks. I want at least a month going in before I investigate any more than what I have already done at that point of time.
So, if that's your question, let me ask you a more vexing question on behalf of Dr. Girija Nair. So, if the person comes at 2 weeks and they're not feeling any better at all,
Yep.
with nicotinamide and a PPI, what would you then advise?
So that then I will, do more investigations. Even if they come back at 2 weeks and they are not even slightly better, or they are at, worse than what they were to begin with, and the symptomatology tells me that patient has more of an epigastric pain, in that case I will definitely go in with better imaging also if it's a pain predominant disease, and if it's a distress predominant disease, probably biopsies from second part of the aorta.
Okay. So, Dr. Nair, I hope you'll thank me. On your behalf, I have taken on the two stalwarts in a big way. Dr. Shahidul from Lakhimpur Kheri, that's near my hometown here, Lucknow. So, Dr. Shahidul, his question is how a physician can differentiate PDS and EPS clinically? Anyone?
Okay. So EPS is an epigastric pain syndrome. So if the majority of your patient's symptom are pain predominant, that is pain increasing after food intake, that would fall under the EPS. And if it is postprandial bloating, that becomes as a predominant feature, just that patient feels very full after eating, or he can eat only small amount and he feels very full. That will come under the postprandial distress syndrome. But as I showed in the slides, there is almost 40% overlap between these features, and sometimes it can be hard for a patient to differentiate pain versus distension. So, we have to take that with a pinch of salt.
So, I mean, in most, if you ask around or give them enough time to talk, they'll probably tell both the two symptoms,
Yes, sir. Yes,
Yes.
sir.
You might actually therefore have to manage it that way. There's a very interesting question from Dr. Ashok Kumar Yadav from Darbhanga. What's the diagnostic investigation for fundus accommodation abnormality? Very
So the
important.
simplest test that you can do is have a full glass of 200 ml of water in your OPD and ask the patient to drink it in front of you in a very fast way. If they can drink 200 to 50 ml of water upfront without any discomfort, that's a good screening test. But if you want a better objective way of knowing gastric accommodation, then the only test, there are two tests. One is viable India, one is not. One is a EGG, that is an electrogastrography, which has a water load inbuilt into its way of testing. The second is a gastric barostat, which was probably there, I think, with Sir when Sir was in SDPGI, but currently I think don't think it's there in India anymore.
So the diagnosis by way of investigations is a little cumbersome.
Yes, sir.
Most of it is actually done in advanced physiology labs, more as a trying to understand the
Research
mechanism
tool, yes,
rather
sir.
than
Yes, sir.
Yeah, very limited availability of it.
day-to-day practice. Dr. Arun Kumar Chaudhary, uh, how should first-line therapy be tailored for functional dyspepsia patient based on symptoms presentation? So his question is PPI, prokinetics, acosciamide, neuromodulators, how would you kind of sequence them or use them in a clinical setting? Any one of you?
So when there is a both the symptom, I think you should start with the PP and prokinetic together. If there is a only epigastric pain predominant symptom, then PPI or PCAB alone is sufficient.
I mean, most of the time we start with the acid suppressant, and then after that, the other one is an add-on. Am I right? That's what we normally would do. So, Dr. Khushi is from Surat. He wants to know, she probably, how long acosciamide needs to be prescribed to a patient for functional dyspepsia. So, I think part of it you answered that it would take at least about a month before you get a significant assessment of response. But let's presume that the person does respond and say at 2 months or 3 months they're well. Then how do you manage? In the sense, do you give it long term? If long term, how long term? And so on and so forth. What are your thoughts?
Generally, sir, prokinetics, though there is a data about the safety, so specifically acoscamide for 1 year, but I think in a stretch, what I practice in 12 to 24 week at a stretch, and then I try to avoid prolongations of prokinetic specifically.
I mean, my thoughts are that PPIs usually come around 6 rupees or so per day cost minimum, I guess. Some go up to 12, and then acosciamide 3 times a day is reasonably expensive. I mean, in that sense, it's not very cheap. Anyway, Dr. Neet Lakhani from Nadiad. So, when should a patient refer functional dyspepsia patient to a gastroenterologist? Very important question.
A patient who is has any alarm signs that we enlisted, a patient who is not responding to standard PPIs, a trial of PPIs for at least 4 weeks, a patient who is losing weight irrespective of his symptoms. That's where I will probably refer them to a gastroenterologist for a better testing, particularly thinking that the patient is not part of the routine functional dyspepsia. And second would be a lot of these patients are tough to treat in the sense that they will have significant overlap. So they will have constipation, they will have IBS kind of features. So when you have those multifactorial patients who have functional dyspepsia, bloating, IBS, constipation, everything coming together, that's where you have to refer them because they need a better detailed management in terms of their medical part.
The second question which I'm going to pose now is linked with the previous one. So, Dr. Anirban Ganguly, is asking, how do you differentiate between postprandial distress syndrome and epigastric pain syndrome? That's first. The more important question, in a patient under 50 without red flags, when do you choose empiric treatment versus upper endoscopy?
Yeah. So I think the first part of the question regarding differentiating, as I said previously, I think it depends on you. I asked my patient upfront, majorly, what do you feel? So in the end, they will probably come down to a symptom. Either it's a pain predominant or a distension predominant. Otherwise, if there's overlap, it's still okay. But the only way to differentiate is history. Coming on to the second question, that below 50, if you have a patient who has functional dyspepsia and no alarm features, you can give an empirical. So there was a study which looked into an empirical trial versus an endoscopy based treatment, and there was acceptance on both the sides. But this study was coming in from the west where endoscopy was still okay. In India, I will give them at least 4 to 6 weeks of decent trial before I ask for a endoscopy in case there are no alarm features. So a good 4 weeks is good enough to check for that below 50 years of age.
What I do in my practice is that I actually, you asked two questions, no? Zubin, you said these
Yes,
are
sir.
the questions you ask. I ask a third question. And the third question is that, tell me, so that's your symptom, but what is your worry?
Mhm.
And I think that's a very important question. If that patient tells me that I think something is going on there, I have an ulcer or do I have a cancer, then it's much better to get the test done so that
Yes,
she's
yes, sir.
also reassured, you're also reassured. I mean, why take
Absolutely,
the risk of missing something? So that's
absolutely.
the third question which I asked. Okay, so now I have Dr. Parthasarthi. Is acoshamide safe in elderly patients or those with comorbidities? Dr.
Yes,
Your thoughts?
yes, sir. So it is safe. There is no extrapyramidal symptoms regarding this. No cardiac side effects were noted. So Acosamide is safe. Yes, it's a more important in a patients who had diabetic gastroparesis particularly. But again, in term of side effect, it is relatively safe prokinetics.
Dr. Dhanjit from Guwahati wants to know how can a physician differentiate FD from organic causes of dyspepsia such as peptic ulcer disease or GERD?
So the alarm features is the first thing, but having said that, I also would like to say that some of these alarm features would do come in quite late into the natural history of the disease. So I think the single most important factor would be if you have a patient who is not improving with PPIs and prokinetics, you're given it for a couple of weeks, above 50 years of age, that's where you should start thinking of organic causes. I think that's something which should be there in, as a single message to probably all of us.
So Dr. Dhanjit asks a further question. What biomarkers or endoscopic findings can assist in ruling out other GI conditions mimicking FT?
So, on endoscopy, the first, you can see a lot of things. You can starting from esophagus itself, you can think of all the conditions of esophagus like eosinophilic reflux disease, GER lax LES. Coming into stomach, you can look for things like gastric malignancies, atrophic gastritis, metaplastic changes in stomach. In duodenum, you can look for duodenal ulcers. You can look for any atrophy in the second part of the duodenum, any fissuring, things like celiac disease, GRDSS, eosinophilia. So there are a huge list which on endoscopy we look for, and most of them are to rule out other things which may mimic dyspepsia. And actually, the definition of functional dyspepsia would entail that we rule out all these things. So on endoscopy, there are a lot of things which we look into, but as I said, 70% would be normal in cases of functional dyspepsia.
Yeah, I might just add that sometimes, although the dyspepsia points to the stomach or the upper GI,
Yes, sir.
sometimes the causes can be lying outside the upper GI.
Absolutely, sir.
Neurological disorders, hormonal disorders, diabetes. So, sometimes those actually have an impact.
Yes,
And
yes,
looking into the stomach may not always be rewarding.
absolutely, sir.
Very good. Then we have Dr. Shekhar Saha, another very important question. Any vitamin deficiency related to dyspepsia?
So B12 deficiency can happen if there is a significant atrophy in the stomach because of lack of intrinsic factor or an autoimmune gastritis, but uh, only upfront functional dyspepsia presenting as B12 deficiency or some other deficiency is less likely.
May I add for the physicians, that PPI use, especially acid
Yeah,
suppressants
usually.
and PPI use, is associated with a few deficiency states. So there is an impaired iron absorption, impaired vitamin D absorption, impaired B12 absorption. So these deficiencies can occur. Especially the omeprazole group has been known to be associated with hypomagnesemia in certain cases. So just for completing the list, these are some of the things which you might keep in mind. The question is which is the cause and which is the effect. So sometimes they are more a consequence of long-term PPI use. So as long as you understand how to fit it into the chronology of your patient symptoms. So then we have Dr. Sanjeev Banik. Can we use vonoprazan and ecoshiamide combination in long-standing GERD? Very important question. You know why? Because ecoshiamide, whatever you talked about, you didn't talk about the LES. And GERD, we seem to believe that the problem seems to be with the lower esophageal sphincter not being tight enough. So, your thoughts on that?
So, in my opinion, the adding ecosamiide over the along with the vonoprazole will not a beneficial in GERD, because the ecosamiide generally it's as you said, sir, it's not functions on the G junction. It is more for funding relaxation and the enteral motility related things. So, I don't think it will add some benefit.
So, Rinkesh, can I ask you, because you are into a lot of therapies also, uh, all the prokinetics that we have, so starting from what have you, domperidone probably is the only exception. So, your etopride, cisapride, mosapride, uh,
Yes.
lesuride, levosulpride, none of them are actually approved by the FDA for marketing or for use in the United States. Okay, and everybody knows that FDA has a fairly strict and stringent rule for approval. We seem to find them very useful because they do work on the lower esophageal sphincter.
Yes, sir.
So, how do you actually deal with this or reconcile with this dichotomy that they don't seem to be safe enough for the Americans to use in their country, but we seem to find it useful and we use it quite frequently, and they're pretty good with regard to providing comfort. So, how do you navigate through this?
Sir, specifically these prokinetics should be used in selected period, like 12 weeks is more than sufficient, and we should avoid the combination medicine, which is a fashion nowadays, and we should give in divided dosage. And yes, it's not approved in US, but in India we see routine in our practice that the patient who have LES problem, they improve with the adding of prokinetics. So it should be reasonably for time limited, and it should not be the combination medicine. That's all.
Good. Then Dr. Paresh from Ahmedabad. If ecoshiamide is a fundus relaxant that improves gastric accommodation, how does it also enhance gastric emptying? Very important question. Zubin, you want to take that little bit
Yes,
into
sir.
your territory? Yeah.
So ecoshiamide is an technically an acetylcholinesterase inhibitor, so it does increase the acetylcholine levels. It not only is a fundic relaxer, it does push the muscles in the gastric body. So that's how it actually also works as enhancing gastric emptying. So the maximum amount of acetylcholine receptor is in the fundus. So its predominant mechanism is there, but the body also is, works. So there is some increased motility. It doesn't work in the interim per se. That's where the other prokinetics would probably work in a better way. And coming on to sir, your previous question on the FTA, so US has not improved any prokinetic except probably domperidone for so many years. And a lot of the patients, they take these drugs like Ganadon or ecoshiamide from outside US. I think the problem is that there not been enough trials in US for all these safer prokinetics, whereas the previous ones like cisapride and mosapride, the experience was pretty bad with a lot of extrapyramidal symptoms in US. So that's why they take almost all prokinetics with a very significant eye, and they don't approve it very easily.
Yeah, but to be fair to them, after all, the PCABs they have actually approved pretty well,
Yes.
which give it to them. And one question last, which has just dropped up, Dr. Kaushal Kumar, combining PPI and ecoshiamide and renal safety. So, there has been concern about the renal safety of proton pump inhibitors. So does aquaciamide make it worse or make it better or no change?
No change, sir. But yes, long-term PPI have some renal issues, and I think we should consider in uh, again in renal patients it should be considered for limited duration, sir.
Yeah, may I ask a provocative question? It bothers me day to day. Is PCAB safer for renal from the renal safety point of view than PPI? I don't know about the recent data.
I think even PPIs are very. I mean, we talk of renal injuries with
Okay.
interstitial nephritis happening with PPIs, but I'm yet to see one, and I'm yet to hear from a nephrologist who is saying, okay, this is a proven PPI induced interstitial nephritis. So PCABs, I think I will not say they are safer; they are equal to it, PPIs, but theoretically, as again studies would say, they are safer, but practical all purposes, I think they are equal to PPIs.
I'll invite you to one of the sessions where we have the people coming down from the Royal College of Physicians of England. In
Yes.
England, all the nephrologists seem to think that their worst enemies is actually PPI. And the major part of the discussions go around the renal safety or the lack of it with PPIs. Indians say that we don't see it. They usually point their fingers back at us and say that we don't look hard enough. So that's the usual story that is raging, but I just thought I'll be provocative before we close. I think that was a very fascinating discussion. If there are no other questions, Dr. Gajanand, can I ask you to come over and take over from me and then give your closing remarks if you have anything else to add? I think you now understand that what a wonderful team I have, So Dr. Rinkesh and Dr. Zubin, and they keep guiding me and teaching me every day. Over to you, Dr. Gajan.